Hello, my name is Melanie Boly. I'm from University of Wisconsin. I'm a neurologist there, assistant professor. It's my pleasure today to talk about biomarkers from electrophysiology and imaging to identify capacity for recovery of coma. I'll give you a little background, of the problem and the current state, some progress, some limitations, and then also where the Curing Coma campaign pieces in. As an overview of the disorders of consciousness, classically we distinguish two components. One is arousal, like eye opening, and the other one is the contents of consciousness and awareness. Typically, these two conditions go together. These two components go together from wakefulness to deep sleep to general anesthesia and coma. You have progressively a decrease in consciousness and arousal going together. There are some exceptions to it. In REM sleep, it's very difficult to arouse subjects, but they have vivid dreams or like during ketamine as well. Vegetative state is defined as a state of preserved arousal with eyes opening, but no signs of consciousness. Minimally conscious state is defined as patients who have some purposeful behaviors or some response to command, but they cannot functionally communicate or use objects. And locked-in syndrome patients are conscious, but they're very difficult to distinguish clinically from the other states because they can typically only have preserved vertical eye movement. So these are the spectrums of disorder of consciousness, and where the traumatic brain injury, severely brain damaged patients piece in. A problem we have with the clinical diagnosis of these patients with disorders of consciousness is the clinical diagnosis is extremely tricky. It's known in several studies, including Colin Schnacker's study in 2009, that is up to 40% misdiagnosis between minimally conscious state and vegetative state solely based on clinical consensus. And there is a need of using standardized scales like the coma recovery scale revised in order to distinguish them. But even in the patients who show no signs of consciousness at the coma recovery scale revised, we cannot rule out that they are conscious. And that's a very distressing problem for families and caregivers. And over the last few years or so, there has been some evidence that, up to 15 to 20% of patients in the vegetative state, according to coma recovery scale, who show no signs of consciousness, they can actually show signs of covered consciousness using neuroimaging. So if you imagine, ask someone to imagine playing tennis in the scanner, they'll show activation in the motor cortex, supplementary motor area. If you ask them to imagine wandering around their home, spatial navigation tasks, they will activate a spatial parietal network. And some up to 15 to 20% of patients in a chronic vegetative state have been shown to do this. And also similar results using common following and the EEG. And more recently, Jan Klassen in the ICU also showed that about 15% of patients that are unresponsive behaviorally in the acute phase, so 2 to 5 days post-injury, also show response to command using EEG during keep opening and closing your hands. So it's not only in the chronic phase, but also in the acute phase that you can find this new entity we call cognitive motor dissociation after acute brain injury. And so there's a need of better clinical tools and also to spread and standardize these clinical tools in order to be able to diagnose covered consciousness better. There is also a lot of issues concerning prognosis in patients in acute coma. And actually, some recent data show that the prognosis is not always grim. So, for example, after traumatic brain injury, study by Jazzino, you can see that about 82 patients that still had disorders of consciousness, DOC, persisting into rehab, 82% recovered consciousness during inpatient rehab, and functional improvement was higher in patients with disorders of consciousness compared to those without, with 40% of these patients partially to fully independent at discharge. So, it's not necessarily because you still have a disorder of consciousness at discharge that you're going to stay like this. In anoxic brain injury, there's even more confounds in estimating the prognosis due to withdrawal of care. But in which is the majority of cause of death for these patients. But in countries where withdrawal of life-sustaining therapy is not performed, 90% of the survivors from anoxic coma are able to regain independence in daily activities. That's where, I'm sorry, when withdrawal of care is performed, 90% of survivors regain independence, but in the countries where it is not performed, actually 42% of survivors have independence in daily activity, and an additional 19% have recovered consciousness, even if some remain severely disabled. So the lesson from this is actually that most survivors from anoxic brain injury, if you were not to withdraw care, recover the ability to communicate with their family at 1 month. And actually, even if patients remain severely disabled, they are not necessarily having a bad quality of life. So there is that study in chronic leptin syndrome that Maria, Orly, Bruno, and others did, showing that actually if you score quality of life in a scale of -5 to +5, +5 is the best in your life and -5 is the worst in your life. Most patients, actually, if you see, the majority of patients have a better quality of life, more than 0. It's actually the mean is similar to that of control of about 2, and there's a bimodal distribution, and the main predictor is actually not the independence in daily life, but more the ability to communicate with the family, as well as some pain and anxiety. But basically, the ability to communicate with the family is extremely important for these patients, and it urges to also find some ways to communicate with these patients with recovered consciousness, as I mentioned. So there are a lot of limitations in the current prognostic markers of disorders of consciousness. Most prognostic markers that have been validated in patients with coma in intensive care are highly specific for poor prognosis, but not sensitive. For example, if you have an absence of pupillary light reflex or corneal reflex, it's quite specific, 99 or 95%, but only sensitive 20%. So you might have a pupillary light reflex present and still have a bad outcome. Same for NSE. The serum markers can be highly specific but poorly sensitive, and same for somatosensory evoked potential. Concerning the good prognosis, the prognostic marker also being developed now. It's kind of newer, but they only have moderate specificity and or sensitivity. I mean, the classic example that is not so new is EG reactivity. It has a sensitivity of 99%, but accuracy is still 80%. Also, being in a minimally conscious state post-injury is actually a sign of a good outcome. So 47 patients that are in MCS 3 months post-injury have good outcome at 1.5 years, and only 3% of patients in AVS. But the number of the previous studies that have validated such markers were confounded by withdrawal of care with self-fulfilling prophecies. And also for cardiac arrest performed before the therapeutic hypothermia era. So we need to kind of, revisit them. And so there is an urgent need to validate new prognostic biomarkers that would be both sensitive and specific, alone or in combination, and take into account behavioral signs of consciousness, withdrawal of care, and hypothermia effect, for example, in the models. And I mean, in this context, I'm going to just mention also one marker that could be promising, that seems to be very promising both for diagnosis and prognosis, which is the TMS-CG. But before that, I also wanted to mention that there might be also some interesting analysis to perform in this context, revisiting this data about which part of the brain might be more important than others. And there is some literature, just in a few studies, but suggesting that some, for example, the frontal cortex might not be so important, and the posterior part of the brain might be more important for patients to recover from coma. So, for example, there was that early study from Kempf, was traumatic brain injury, where you can see that injuries in the posterior corpus callosum and surrounding white matter predicts 214 times more chances to stay in a vegetative state, and brainstem was actually only 9. And then these studies with anoxic brain injuries, where you can have this posterior restricted diffusion, and patients never recover from coma. A very nice study from Wu et al. In radiology showing that in a multiple logistic regression analysis, if you actually do a whole brain model, you will have a significant prediction for the restricted diffusion of recovery. But actually, the most informative regions are occipital and parietal cortex, as well as putamen. But actually, when you take these three areas together and you don't take the frontal lobe, you get a better model. So it looks like, some site-specific analysis also of which brain areas would be more important than others could also be improving prediction models. And then what about TMS-EEG? So TMS-EEG is a tool that we have developed, Marcello Massimini, Giulio Tononi, and then I helped also in the coma studies to detect covered consciousness, but also there seems to be a lot of promising information about prognosis in the response. So what you do is you have transcranial magnetic stimulation to stimulate a part of the cortex, and you record the response with EEG. If you're awake, you have a complex response pattern, the different brain areas to different things, and it lasts long. It lasts like 300 milliseconds with the signal moving around the brain. If you're asleep and unconscious during the early night, then actually you have a stereotypical slow wave that stays in the same place. If you're in REM sleep in the bottom there, even if you cannot communicate your consciousness, covered consciousness during REM sleep, you find a complex response. And in different states of anesthesia, if you have midazolam, propofol, xenon, you find the same pattern that during deep sleep, a very stereotypical slow wave when you're unconscious. But if you have ketamine anesthesia, that was a study we performed in Belgium, and subjects were dreaming, the response is complex again. And so across these different conditions, we see a very clear differentiation between conscious and unconscious states, which led us to try to develop a new algorithm to try to reduce this information in one number. So what you do is you do statistics of the response over time. You obtain a binary matrix of the sources and time response, and then you can zip that with Lamper-Zip complexity and obtain a number we call perturbational complexity, or PCI. PCI is low if you have a small local slow wave. It is also low if you have a big stereotype response, but it's actually not differentiated. It's only high if the response is both differentiated and integrated, so a complex response. And using this number, PCI, we then did the validation study with a benchmark population that was able to report like sleep anesthesia and patients that are communicative after brain damage, and then apply this to see what we were finding in patients with disorders of consciousness that cannot communicate. And the results were actually extremely promising. So this measure of PCI, if you draw an empirical threshold of 0.31, you actually can separate with a sensitivity of 97% and specificity of 100% the conscious and unconscious population. So it's extremely robust if you take the maximum value at the individual subjects level across both wakefulness and subjects with brain damage compared to unconsciousness during different states. You find a very clear demarcation, and also importantly, even if there is a covered consciousness, PCI can detect that very sensitively. And so applying this, empirical distribution to the coma patients, what we found is that the patients in minimally conscious state, we actually have a sensitivity of 94% to detect consciousness in their case. And patients in a vegetative state had actually three different patterns. Some patients, mostly after anoxic brain injury, had zero PCI, so no significant response to TMS. Most of them actually in blue had low PCI, like the sleep and anesthesia value, and about 19% of them are actually some high complexity suggestive of covered consciousness. So these three different patterns: no response to TMS, a sleep-like response in the majority of patients, and then there's a complex response in about 90% of patients in vegetative state, which is the same range than what we see for imagine playing tennis and active paradigm responses. So this tool is actually something that we're really trying to develop in larger studies now to be available for clinicians, hopefully in the future. But just to show you that this is a promising tool that could be used to detect covered consciousness in the ICU. And so what we're trying to do now is develop a user-friendly interface, and also a compact interface for immediate readout. We are developing a user manual for to train users to perform TMS as if you were kind of doing an ultrasound, to find a good response in the brain. And you can find online, as soon as you stimulate the brain, that a response in the topography, and you can evaluate the quality of the signal and compute PCI. So that's a multi-centric study we're starting now to validate these procedures in healthy volunteers and then apply that to the first populations, and first in a subacute phase, and then hoping to move to the ICU as soon as we can. Yeah. So, and then in another thing I wanted to mention before I move on to the Curing Coma campaign is that actually there is a lot of hope. There's a lot of different therapies that have been developed and validated in some that are useful in some patients to improve prognosis. So that's a quote from Olivier Gossery. We have transcranial direct current stimulation, TMS, lamentanine, apomorphine, zolpidem, and then stimulation from the arousal centers and from the periphery. Deep brain stimulation, focused ultrasound. The problem we have is actually we don't know which patients are going to respond to these therapies. So there's a need to stratify patients toward precision medicine, and our hope is also that maybe TMS can help, to help to stratify these. In particular, maybe the patients that have no response to TMS, we could show that they have worse prognosis. But the most important maybe are these patients that have sleep-like responses. Maybe these ones would be the ones that would be responsive to a stimulation, the arousal centers and therapies like this. And in patients with high complexity and suspicion of COVID consciousness, maybe in these patients, you could try to develop these brain-computer interfaces to try to communicate again with their families. So that's I think these promising avenues are coming in the alley. But also, the Curing Coma campaign initiative is very important to try to also define scientific gaps that we need to address and improve the science, leading to better therapies and treatments and diagnosis and treatments. And so there's one part of the Curing Coma campaign, one working group is actually trying to deal with heterogeneity in the coma and try to refine the endotypes. So going from just that classification I showed you of coma, vegetative state, minimally conscious, to something more refined, where you would have some classification based on molecular and network level dysfunctions, brain function and brain structure, as well as the clinical features. So trying to really move across and try to track actually the recoveries and the recovery potential based on these different characteristics. There is also a lot of importance of trying to combine different scales. So going from the microscopic scale, the molecular genetic understanding, cellular understanding, to the circuit understanding, using both animal and human neuroimaging models. And so we can integrate these multi-scale model, the brain structure and brain function differences, as well as theories and experiment, try to integrate the science better so we can design better treatment, prognosis, and diagnosis tools. So there's a lot of need to talk between disciplines. Also, we know that there are different types of trajectory for recovery. Some patients recover kind of more linearly and quickly, and some actually have a prolonged delayed recovery. We still don't understand why. And there's a need of a personalized healthcare delivery model and better prediction of this long-term course. As well as for the therapies, there are so many therapies I showed you that are available. We need to really move towards precision medicine, developing a conceptual framework for the therapy mechanisms, and the design of clinical trials has to be optimized, and then using precision medicine approach based on the heterogeneity, based on these different categories I showed you, to select therapeutic pathways and develop biomarkers for the therapy response, optimize the timing and dosing of this intervention, as well as maybe combine the therapies. So, but then all this, dealing with a lot of heterogeneity, actually requires international efforts, international multi-center clinical trials, and that's where we really hope also to involve you, as a community, in order to participate in these efforts. So that we can move the science closer towards the patient bedside. So in conclusion, we're moving medicine in disorders of consciousness with the efforts of the Curing Coma campaign, giving a lot of hope for this to be really possible. The research on brain function in patients with disorders of consciousness over the last few years has led to definition and validation of new entities. So there's progress there. Yes, we kind of discovered, the minimally conscious state, plus and minus language abilities, cognitive motor dissociation syndrome, these patients that are covertly conscious and identified through neuroimaging. But, there is some ethical implication of this discovery. So, for families, it's very important to know if the patient shows some signs of consciousness, if there is actually also some hope to recover consciousness. But beyond the ethical implication of these discoveries for withdrawal of care, new data also suggests that these patients actually recover better, and also long-term recovery can be with an acceptable quality of life in many patients with acute disorders of consciousness. There is an urgent need for further research on the diagnosis of covert consciousness, including TMS-ED, active paradigms, and other tools, resting study from MRI, for example, which one are the best biomarkers alone or in combination, better characterizing the behavior, brain connectivity, and molecular endotype for different disorders of consciousness mechanisms, so we can have different targets for therapies, validation of new ways to stratify patients with a precision medicine approach. So we can also optimize prognostic modeling and also clinical trials. And so the initiatives such as the Curing Coma campaign are instrumental to allow large-scale collaborative studies that are necessary to accurately model the heterogeneity of coma patients in disorders of consciousness across its many dimensions, and translate clinical research into practical tools that can further help to guide withdrawal of care decision and improve therapies and outcomes. So that's it. I wanted to thank, all my team, also Giulio Tononi, Chiara Cerelli, Adrian Owens, Stephen Norris, Caroline Schnackers, Carl Friston, Hal Blumenfeld, Christoph Koch, and many others that really helped with my path, and with this work, Michael Deringer and Robert Stevens as well, and Brian Edlow. And looking forward to work more on this with all of you. And please send me an email if you have questions. Thank you so much.